Oh, hello and very good morning, good afternoon, and a good evening from the South Asian Division of the Royal College of Psychiatrists. I'm Rajeshri, and I welcome all of the participants. We've had a fantastic registration for this event, and no wonder because we've got a very interesting and a very relevant discussion this afternoon or evening. I'm really grateful to our speakers who have been very encouraging to organize this event. And we have with us the Dean of the Royal College of Psychiatrists, Professor Subodh Dave. Hello, Subodh. Lovely to see you. We also have Professor Dr. Kishor from JSS Medical College, a very, very reputed college of international ranking from Mysuru in India. And soon joining us also will be Professor Mohan Isaac, all the way from Australia. Now, today's topic is about capacity building in psychiatric education. You know, our college, a fundamental work is training and training psychiatrists for the future. So all across, the priority remains on how much we're already doing it, but there's always room for more. So this particular webinar is going to be focusing on what are the innovative capacity building, and this time we'll be talking in particular context of the South Asian division, because not only in India, but across these countries here, there's been a major expansion of medical undergraduate seats, postgraduate seats in psychiatry. There are trained faculties, but there's still a treatment gap. Now, the question is, why do we still have a treatment gap? We are having psychiatrists. What are we doing about it? And what else can we learn, really? Because it's a whole collaborative learning experience we gather together here. So what do we learn together from people like, Subodh, from people like Professor Kishor, who've done extensive work over more than decades, really, to bring together on this platform. So today, what you're going to get is a very crystallized, synthesized thing of collaboration, of modern medical education, looking into the Royal College point of view and bringing it to in the context, making it relevant to South Asian Division. But before we start and I introduce my speakers, there's a quick housekeeping that Patricia, a lovely host, has asked us to do. And I would just say very briefly, please use the Q&A function for questions. We will still keep the chat box open, though we've had more than 250 registrations. So we are hoping people to join, but the Q&A function will be open. The event will be recorded and will be shared. You will also be getting a participant certificate after the webinar once you've joined and completed this webinar with us. All the speakers, panelists, and participants' views and comments are their own and not the established views of the college. If you have any technical issues, please try and leave and rejoin. However, if still that does not work, we will include Patricia's email here, so just do drop a line. So please, if you have any questions, please use the chat box and the Q&A, and hope you have a great time. On that note, I would like to introduce our first speaker, who realistically everyone is aware, Professor Subodh Dave, our Dean. And I'll let Subodh do the rest of the introduction for himself, and straight away we'll start with your presentation, Subodh. Over to you.
Thank you, Rajeshri. First of all, congratulations on your dynamic chairing of the South Asian International Division. I think it's we can see the impact of it. I think you're bringing together a fantastic organization like the Indian Teachers of Psychiatry, I think, led by Dr. Kishor. I think, Dr. Kishor, you're also doing great work, I think, in developing that medical education capacity in South Asia. So we're proud of the work you're doing. Rajshri, it's really credit to you to also bring in BIPA and other diaspora organizations and work together with them, because we know that South Asia, I mean, this is South Asian. There are more South Asian psychiatrists outside South Asia and countries like UK, USA, Canada, Australia than there are in South Asia. So I think it's together. It's a very big force, So congratulations, Rajshri, for bringing this together. And this topic is really important. I think, firstly, in my dean's role, I think I took a pledge in the very first year that every talk I would do, I would remind people that, because I would ask this question, and I could do this now. I can see lots of friends in the audience, but some whom I don't know. as to what does a dean do. And I think, the typical answer that comes up is the deans to do with training, education, exams, assessment. Hardly ever would anybody say that the dean's role is also workforce. And that I think is can seem like a pedantic thing to pinpoint that the dean is for training and workforce. But I took a pledge that every chat, every conversation I would have, every talk I would do, I would remind people that my role is to ensure that training is in the service of developing a workforce that can have the right numbers and the right skills to actually deliver outcomes for our patients. And that seems like an obvious thing, but it can be easily forgotten as to how do we get the workforce that is trained appropriately. And that is the job of medical educators. So don't let anyone tell you that that is an unimportant job. That is absolutely the critical job. And believe you me, I think as a dean, I speak to my counterparts across the world. Certainly in India, I think Dr. T.S.S. Rao, our new president of IPS, is online. I think I saw you, Dr. T.S.S. Rao. So, congratulations and welcome. But I speak to leaders across the world, and I think one thing they all tell me without doubt, and here as well in the UK, Rajshri, every single employer tells me that their number one issue is workforce. So workforce numbers, workforce skills are the number one issue. Now, people have this idea, even in the UK, that somehow if you need an addiction psychiatrist, you just advertise in the NHS jobs website, and somewhere, an addiction psychiatrist will materialize. The reality is that in this country, we had something like 150 addiction psychiatrists 10 years ago. Now we have a quarter of that number. So unless you have a forethought and planning, and it takes several years to develop an addiction psychiatrist. You can't make an addiction psychiatrist from nowhere, right? So I think you really require that forethought and planning. And then medical educators need to be very much involved in that. So I really applaud what you're doing, Dr. Kishor. I think that is absolutely the key thing. Now, I didn't want to kind of, talk a whole lot about my biography, but I think why I feel that I'm qualified to talk about this topic, because my day job, I think, is as a liaison psychiatrist, but I have a split academic role. My academic role is to do with undergraduate medical education at the University of Nottingham. I'm also professor of psychiatry at the University of Greater Manchester. And in my dean's role, I deal with postgraduate training issues. Now, to me, the title of my talk is really, in a way, there's conflation between the two roles, because when you think about undergraduate experience, postgraduate experience, I feel that they are kind of related in a way, because of the thing that I just mentioned, that ultimately, if you think that training is in the service of developing the workforce, the right kind of workforce, then you realize that at the undergraduate training level, you need a sufficient number of people to come into psychiatry, but you also need the 95 or the percent odd people who won't choose psychiatry, won't come into psychiatry, to also be mentally, mental illness literate, to be literate in psychiatry enough, because they will encounter psychiatry, whether they're an orthopedic surgeon or whether they are a urologist or a gynecologist. And I see that in my role. This becomes particularly relevant where there is a shortage of professionals, like countries like India. Now, India, population of more than 1 billion people. South Asia, Rajshri, very big area. When you think about it, big population. People think and assume that we are a tiger economy. We are a young population. There's almost a kind of a thing that, well, people in the West are getting older, their fertility rates are low. The reality is that India is aging very rapidly. We need enough number of old age psychiatrists. So that's just one example. I mean, and which is why at the college, I think as dean, I kind of launched the postgraduate diploma, the first ever diploma at the college in old age psychiatry, so that we could begin to address some of these issues. Because that is a problem that is across the world. People are getting older. Things like dementia, older adult mental illnesses are really coming to the forefront, and care of elderly people, I think, is becoming a real issue. And I saw this firsthand. I was responsible for setting up the postgraduate training in Zambia, and when I went there, um, I was invited because I'd led Dr. Kishore, a similar upskilling training program in Dr. T.S.S. Rao's JSS Medical School in Mysuru, and a similar program in KEM in Mumbai. We did a 2-3 day program, kind of bringing up train the trainers kind of program. a medical education focused program. And I think what we realized, and I think I've since then, it's something that I've realized even relevant to the UK, is that we think that every medical school wants to train globally competent doctors, so we all have curricula that include similar. So I think if you pick up the curriculum in Grant Medical College in Mumbai, or in King's College in London, or in Bellevue Kaplan in New York, they're very similar. Now, the reality is that the population needs are not similar. The reality is that the population needs are different. If you go to Zambia, country of, when I started, country of almost 15 million people had 3 psychiatrists in a whole. How can their curriculum be the same as a country like the UK, where we have 1 psychiatrist per 10 to 14,000 people? Very, very different ball game, right? Completely different ball game. And yet you find that the curricula were very similar. So that was my first challenge. I said to my Zambian colleagues that, please send me the curriculum. And I looked at the curriculum. I said that the first cohort of psychiatrists will have to write the Mental Health Act. They'll have to devise the new mental health policy in the country. Where is the leadership experience for them? So unusually for a curriculum, we put in the curriculum that they had to go and attend the cabinet committees, the health select committee, just to form that network. Now, why would you put that in a medical curriculum? Some would argue, but you can see why it is relevant in the context of Zambia. It may not be relevant in the UK. But I think this is what happens. I think that the curricula are often designed in a global context, but not necessarily to produce a workforce that is locally invested, locally relevant. I think that is one take-home point I would say for all curriculum designers in the room, is that how do we design a curriculum that is actually delivering a workforce that is locally invested, locally relevant? And this is important for 2 reasons. One, I'm just giving the example of the UK now. Even in the UK, we have, it's obviously one of the largest economies in the world. It's quite a rich nation, developed nation. It's got a lot of resources. But if you look at rural, coastal, remote communities in the UK, mental health outcomes, physical health outcomes are much worse than other parts of the country. So that is the reality in the UK. You can imagine the disparity in countries like India, other countries, huge disparity. So if somebody's going to work in a rural area, a rural psychiatrist, their training needs will be different. And you can imagine that in India, where we know the farmer suicide is a real issue. In the UK, farmer suicide is a real issue. We have farmer suicide here too. I think access is a factor. We all know that. I think how do we kind of create a psychiatry curriculum that is delivering to that? So I've set up a task force looking at that, or how do we invest in rural, remote, coastal mental health? So I feel that that's the kind of planning and thinking that we need as medical educators. I think other thing that's happened, maybe particularly in the UK, less so in India, less so in South Asia, I hope it's true. Actually, you have worked in both systems, so you will be able to tell us more about this. But I feel that in the UK, while our training is considered the best in the world, and with all respect to everyone else here in the room, I think that is just feedback that I've had individually from my counterparts. They all say that, even people in Canada, Australia will say that openly to me. So I think that is good. I think what is not so good is that we've lost our trainers being invested in the success of their trainees. And I see that a lot in South Asia, where an individual trainer, individual consultant is really invested in the success of their resident doctor. And that is really important. I think that sometimes I feel that can get lost easily. And how do we have a medical education system that retains that is really critical. Another field, medicine, psychiatry, these are clinical subjects. We learn on the job. So of course, there has to be some classroom teaching. There has to be some learning, in webinars like this, but there's a lot of learning to be done on the job. That means giving the trainers the time to teach on the job in a busy outpatient clinic, in a busy inpatient ward. We have to give them the time and the skill. And I'm not sure that always happens, particularly in the Western context. I feel that that's a two-way learning. We need to learn from countries like India, where I feel that's probably still happening, that you learn on the job, on the ward round, in the outpatient clinic. And that's something I really want to, feel that that's something that we need to kind of take in as a given. So you can see that for me, I think that making that training directly and explicitly linked to patient outcomes has to be the key outcome that we judge our curricula, our assessment systems by. And that's what I think I've tried to do as dean. I think I've tried to draw a straight line. I think I've given you an example of addiction services. I think we tried to have conversations directly with providers of addiction services. A lot of them are who are in the private sector, in the independent sector. And we've tried to have conversations to see how can we place our resident doctors for training with them. So outside the NHS, but how do we safely and effectively train these new edition psychiatrists. And that guidance, I think, will be released in the next week or two. I think, however, there's a broader problem, I think, I think in the way our medical education is designed. I think medical education is largely pathology driven. So I think our current model of medical education is that we'll teach you in year one the anatomy of the liver, and then we'll teach you the physiology of the liver, and we'll teach you the biochemistry, how to interpret blood tests. Then we'll teach you radiology, how to scan, so on and so forth. And then we'll teach you how to do liver biopsy, and then we'll teach you how to fix the liver. And that's the pathology-driven model that also conveys the idea somehow that medicine and psychiatry is an individual enterprise, that I can sit in my own clinic and I can deliver the best outcome for my patient. Now, even if you're the best surgeon in the world, you might be the best kidney surgeon in the world, and as a student, I kind of worked with some of them. You can't deliver the best outcomes for your patient unless you have an ecosystem around you that is designed to deliver the best outcomes for your patients. I think that is sometimes something easily forgotten. And I feel that medical education, good, honest medical education systems will remind their students about that you alone can't deliver a good outcome for your patient. You have to work with the ecosystem. I think in psychiatry, we have that advantage. We are systemic thinkers. We are biopsychosocial thinkers. So we know that instinctively, that it's not about just one person doing it alone. We have biopsychosocial expertise, but we have to use that expertise with the wider ecosystem. We have to influence the wider health determinants. And so I feel that is something that has to change in the whole wider medical education system. And I feel the psychiatrists can lead that change because we are the leaders in biopsychosocial, holistic, person-centered care. And this is a real problem. I think even if you look at good medical practice, the GMC guidance, Rajshri, you'll be familiar with it. Some of our UK colleagues in the room will be familiar with it. It talks about doctor-patient relationship. Nowhere does it talk about the doctor-community relationship. The word community does not even appear in it once. So the whole idea is that as a doctor, you're only responsible for the patient that you care for. Now in psychiatry, we know that a lot of our patients come through the door, but a bulk of our patients don't even make it through our doors. And that morbidity is sitting outside. David Goldberg's work was very instrumental in, entrenching it in our minds. So we know that to be a fact. But yet medical education somehow ignores that somehow it's thinking that when the patient comes in through a door, you treat them. What about the people who have not made it through a door? How are we going to influence them? I think that is something that medical education needs to really address. And I hope that the work you're doing, Dr. Kishor, will be influential in addressing that. And so I feel that then also leads to the kind of model that we've seen where we talk a lot about evidence-based medicine, evidence-based practice, but there is a far more disproportionate focus on generating evidence than applying that evidence. And so we see this almost 15, 17-year gap between the generation of evidence, the availability of good quality evidence, and its application, its benefit to the patients. Now, we wouldn't want that for our family members, that there's a 15-year delay in them getting the best evidence-based treatment. But that is sadly the reality of today's modern medicine. And as a small way of trying to address that, I started the Dean's Grand Rounds. I think, Rajshri, you've been part of that. I think you're working on another one. Guys, a plug for it. Please do come. I think these are fantastic initiatives that Rajshri is working on locally and then regionally. And we try and address the gap between evidence and practice. We start with that individual patient story or a community story that illustrates that gap between evidence and practice. We then talk about what is the academic evidence to show what the gap is. Then we talk about the impact of that gap, not just on that individual patient, but on the wider community, the wider region. What is the impact of poor perinatal mental health services, Rajshri, in the whole of South Asia? What kind of impact does that produce? And I think that is the kind of thing that then really gives us that, understanding that our role has to be beyond the doctor-patient relationship. So I think that's something that we've been really focusing on. And the Dean's Grand Rounds have been very successful. Rajshri, some of the ones you organized have been very successful. We've had more than 1,000 people attending. So well done, you. I think it's been really credit to you and the team that you've organized. And I hope that the next one is equally successful. And so I feel that that's something that, that addressing that gap in evidence and practice is something that I feel is really important. I think, and then thinking of our role, I think would then enable us to start thinking about how do we create that spectrum of skills that are needed. So one of the skills that I feel is really lacking is medical leadership. And I think that psychiatric leadership particularly, I think, how do you organize a good system I think as we talk, Professor Mohan has walked in, who is a living, breathing example of what that good psychiatric leadership looks like. And he's a real role model for that across the globe. But you can see that's it's a real challenge because, even today, and then this is a recent example from the USA, stab wounds were increasing coming through the ED. The medical director of the ED thinks that I don't have enough surgeons to operate on stab wounds. The immediate response is, I need to upskill my surgeons so they can operate on stab wounds. I need more surgeons who can operate on stab wounds. Whose job it is to think that why are there more stab wounds walking through the ED? Whose job it is, And I think that's where some of that medical leadership gets lost. And I think we sometimes get focused on supply side, that, well, let's get more people in. We don't think about prevention. That's something we realized at the college, that's something we need to be really involved in. So we changed our curricula. We've created those lenses, that two big lenses. One is a person-centered care lens, thinking of biopsychosocial expertise, but also that public mental health lens, thinking about prevention, not just primary prevention, secondary prevention, tertiary prevention, even quaternary prevention. And I think we've created this public mental leadership course that really creates that first generation of leadership. So you can see that at the postgraduate training level, we are really investing in creating that psychiatric leadership. And that's really in our curricula. And the final thing I think I would say is that we all know that the digital world is changing. We are having this meeting, sitting in different parts of the world. I think we need to leverage technology. I think there are pros and cons to every technology. We know that in this modern world, even now with all the digital thing, actually in-person meetings have a special flavor, far more powerful, far more engaging, far more relational. But at the same time, I think, tools like AI are here. I think we need to kind of work with them safely and effectively, cautiously, but proactively in an engaging fashion. And so at the college, we launched that digital literacy framework. And for me, I think that's really quite important that we make sure that the next generation of our psychiatrists are fully digitally literate and are able to work with digital technology safely and effectively. And my final point, I think, before I end, I think probably got 2 minutes, Rajeshri. Some of you may know that I'm a trustee with Doctors in Distress. I think what we are seeing with the wider medical workforce and wider healthcare workforce is rising rates of burnout, mental illness, and stress. Dr. Kishor, this is a real issue for you in India. I know that. Rajshri, is an issue in South Asia. I've worked with colleagues in Sri Lanka. They've said the same thing. Suicide rates amongst our colleagues is rising, sadly. Burnout, stress, mental illness is rising. Reporting of neurodivergence and neurodivergent conditions and neurodivergent, or illnesses associated with neurodivergence are also being reported more. So there's a whole lot of, changing landscape. And I think psychiatrists need to offer leadership in that wider healthcare landscape in improving the health of the workforce, the mental health of the workforce specifically, but the overall health, because you can't have good physical health without having good mental health. And I feel that capacity, I think when you build capacity, Dr. Kishore, it's building the psychotherapy training capacity, it's building that occupational mental health capacity, because occupational health is often designed to think about, having a ramp for somebody to wheelchair themselves to their office or to have visual ability disability aids. They're not designed sometimes to think about our illnesses. They're not designed to think about stress, mental illness, anxiety, depression, even bipolar disorder, schizophrenia. We all have colleagues. We know that this is not as if you can't have a surgeon who has, you can't have doctors with mental illness. You have doctors with mental illness too. And I think that's something that we need to do more of. I think one of the programs that I've devised, which has been very successful, it's become a national program here, is Doctor 1 in 4, where doctors with lived experience come and talk about what does it mean to be a doctor with lived experience of mental illness, with lived experience of chronic physical illness, with lived experience of substance misuse. These are all real issues with doctors, and yet we sometimes sweep it under the carpet. And I think creating that kind of program, I think, is really important. I know, Dr. Kishore, you're working with some colleagues in the UK, Arun Kishor, Saju. I think this is great work you're doing, and I hope that this will help the mental health of our workforce. And so I think I will kind of end with that. I think just with reinforcing 2 points. One is that we need to really thinking about how do we influence patient outcomes. So the patient has to be the heart of all our educational endeavors. I think we have to think in terms of medical education being locally relevant and producing a locally competent workforce. What is needed in Perth, Australia won't be the same as what is needed in Mumbai or in the Lake District in the UK. So we need to think about that. And I think we all need to work with our funders and policymakers and governments to make sure that there is enough investment in educator and educational capacity, because that's often ignored. And then when there's service pressure, clinical pressure, education is put on the side and the back burner. So that's something we need to really work on. And my final thing is that we have to protect the mental health of our workforce. And I think having programs in our curriculum itself, in our educational capacity building exercise that protects the mental health of the workforce is absolutely critical. So I'll stop there, Rajni, Kishor, and Mohan. Thank you so much.
Thank you. Thank you, Subodh, for a very well structured and exceptionally relevant points you've highlighted. And I would like to start with the final point about, in the last one you said about protecting our own selves. And sadly, we really heard about a death of a young psychiatrist who had just recently started her postgraduate training in psychiatry. And we're not sure, but it's very sad that, of course, we lose people very often. Many doctors we've lost. Some could be protected, some could be saved, and that is very vital. And of course, unless we protect ourselves, we'll not be able to deliver to the best possible that we can. So burnout has to be presented. And Professor Dave has sort of made very good points, relevant points, talking about, we need to be far-sighted. We just can't be thinking in our today's boxes and thinking, okay, we are fine. As long as my things are all right, my next 10, 20 years go well. What about the next generation? It's something about this global climate issues. We're not really thinking hard. We are thinking, but we need to think probably harder about the next generations to come. So the way the education that the curriculum that is being built for the future generation of psychiatrists is something that is going to sustain this whole specialty in itself and sustain human beings in itself, because you really cannot do without mental health. Tell me, when I take my classes, I ask them, can you remember any specialty, especially for all the other, other specialties, every specialty patients come, they may or may not be related with psychiatric problems, mental health problems. So we seem to be in a center, and it has to be very specific. As you said, one size doesn't fit all. So on that note, that it's vital to look after ourselves fundamentally, to think about the future generations. And what is the idea? A better patient care. So patients are at our heart. And whatever we do, whether we train our doctors, look after ourselves, look into this access, network, public policies, we should think, what if I become a patient tomorrow? What would services I like? And what if I might be in India today, I may move to Australia tomorrow, I may go to Zambia tomorrow, I may have friends, and we are wide, we are just one big family in this world today. So services have to be different. So excellent start, I'm sure. And please send your questions here. And we will definitely take this towards the end of the discussion. And on that note, namaste, Professor Mohan Isaac, and a very, very good evening, sir. It's pretty late in Australia, but we know sir is always very energetic. So, and thank you for being with us. And I think he has been instrumental in this is an advisory role for IToP, and it was really IToP's brainchild to bring us all together today. And so we have the president of IToP, which is the Indian Teachers of Psychiatry, Professor Kishor, very eminent senior psychiatrist and head of the department at JSS Medical College, Mysuru, deemed university. He's also the chair of the Postgraduate Psychiatric Training Subcommittee of the Indian Psychiatric Society. He's got lots of other accolades. I'll let him do the talking rather than myself. Over to you, sir. Thank you.
Thank you so much. It's a sheer delight to be in this program. Can I also share my slides?
Yes, please. You can share your slides.
Yeah. Is it visible?
We can see them.
Yeah. So it's a sheer delight to be in this important program on the collaboration between the IToP and the Royal College of Psychiatry. And when we discussed with Professor Subodh, how do we work together in capacity building in psychiatry education, and we wanted to share our experience from India. and it has relevance to many of the things we are going to discuss. And I want to convey that many of the participants in this program, whether it is from the north of India, from Jammu Kashmir to Kerala, the south of India, and also many people across the world. We have people from Bhutan, Bangladesh, Pakistan, and many other countries who are participating. And we also have postgraduates. We have people across different departments, and I believe there are far more people than we imagine. And I want to say that my primary affiliation with Department of Psychiatry at JSS Medical College and Hospital and JSS Academy of Higher Education and Research at Mysuru in down south India. But I also closely associated with the Indian Teachers of Psychiatry and the Indian Psychiatry Society PG Education Subcommittee. And I also hold the academic lead of the Indian Journal of Psychiatry and the Indian Journal of Psychological Medicine. And I want to say teaching is a work of art, and we need to always recognize ourselves as the teachers. So I'm going to take you towards what we have been doing, but I should always acknowledge psychiatry teachers from India and abroad who always give us new thoughts and new ideas. And the IToPs and Indian Psychiatry Society, the president is here, Professor T.S.S. Rao. We have postgraduates here. The undergraduates also give us a lot of ideas. We should be thankful to them. There are super special courses, and the students from DM, DPM, MD, all the people who have contributed. And obviously, as Professor Subodh was saying, the patients and their family members who allow us to learn and contribute. And the Royal College of Psychiatrists and the Dean's Office who thought about this novel program, and the South Asian Division, headed by Professor Rajshri Ray, very dynamic leader down, and the BIPA and the president. So I would right away take you towards why do we look for the innovative capacity building strategies in psychiatry education? What is the need? What is the evidence? And Professor Mohan, who is here, who has guided us on many things, has spoken extensively on community mental health. We need to look at the fact file. One of the important parameters is about the mental health in India. As per National Mental Health Survey, 1 in 7 has one or other psychiatric disorders. And we should remember that the public health services in India, over 200 million people need treatment, and the gap is immense, with 85% of people do not have access. Very interestingly, India is one of the has largest number of medical colleges, which trains MBBS graduates, postgraduates, and so many things. So what we really need is what is the infrastructure we have? You will be amazed that every new medical college gets added every year. So we have more than 800 medical colleges in India. We have around 22 institutions of national importance, like All India Institute of Medical Science across India. We have annual enrollment of more than 130,000 medical graduates. At any given point of time in India, we are training nearly 1 million medical students. Many of them are in many different countries of Asia. They get themselves trained and they come back. So we think that there are not less than 3,000 to 4,000 psychiatry teachers involved in undergraduate medical education. And as Professor Subodh rightly said, we have to focus on these undergraduates because they are enormously in number, and their ability to serve the community is phenomenal. Paradoxically, in India, until 2019, there was nothing in MBBS training as mandatory in relation to psychiatry learning. So you can imagine years and years of graduates who have moved out without any kind of knowledge, awareness, or skill in psychiatry. That is a huge paradox. So But the competency-based medical education, which came in 2019 by the National Medical Commission, they said that you should have 40 hours of psychiatry theory, 6 weeks of clinical postings for undergraduates, and 2 weeks of internship. Very interestingly, we also saw what we realized is the primary healthcare centers, which are backbone of Indian medical care across India, manned by the MBBS doctors, since there was nothing in the MBBS graduates for learning in psychiatry, and they need not learn anything to practice, this made a way for we have to really customize and work with the psychiatry faculty so that they can do something. And we started to look things from that perspective, but we were also doing a lot of our backdoor work to see that the government also makes sure that there are some kind of certifiable skills. And we were successful that in 2024, 2 certifiable skills became mandatory for every upcoming doctor. One was primary care management of depression and suicide risk assessment, which helps either ways. If you want to look at mental health of the doctors or suicide among doctors, we need to have some capacity building among them to ensure that they are able to use these services. But we should remember a large number of MBBS graduates are learning from coaching centers in India. They have guides and notes, and they are using artificial intelligence rather than patients. So this is a growing concern about how the upcoming doctors are learning. So this also becomes a huge issue. Let's look at the postgraduate education. You will be amazed that more than 300 medical colleges in India are now offering postgraduate in psychiatry, DPM, DNB, MD, and we have more than 1,300 postgraduates now. At any given point of time, there are 4,000 psychiatry trainings in India, and we have not less than 3,000 psychiatry teachers involved in the training of this postgraduate. So when you look at the capacity building strategies in psychiatry education, these are the faculty who make difference. Very interestingly, as everybody knows, many psychiatry postgraduates in India migrate to various parts of the world. They are the workforce in UK, Australia, Middle East, and many parts of the world. So what happens in India? Some of the best training practices, if we implement, if we work with the psychiatry teachers, we are likely to have better quality of care across the world. This said, we have to look at why we have to innovate faculty building strategies. And I would like to look at complex scenario of psychiatry education in India, the competencies required, the quality of training, and we should go back to this concept of tip of the iceberg. You will come across enthusiastic, competent psychiatry teachers, training and training institution and postgraduate. Their number is very small. Whereas a large number of people, there is poor quality of training, primarily because various challenges. The National Medical Commission this year, it made, even if you score minus 40 out of 800, you will qualify to take up, provided you pay the fees. Last year, it was 0 percentile. So you can imagine that postgraduates who come to the various branches of medical sciences, including psychiatry, may not have the required undergraduate training, but they come. And in India, you can access post-graduation education by payment of the fees. We also should talk about trainers. There are absent faculties. There is a major issue that in many institutions, faculty do not come to train. There are unskilled faculty, both in psychiatry and many other fields. But we also have training institutions which pop up overnight. There are so many medical colleges which have come in the last couple of years that they do not have resources. So we should be mindful of this concept of gold medals in psychiatry, about high marks, about ranks. They may not assure competencies which are required for postgraduates. That is the crux why we need to work on the capacity building of the faculty. Now we have to answer another question. is there a real need for capacity building of faculty? The question is, are faculty really interested? Are they interested across India, including institutions of national importance and AIMS institution? Even though the earlier Medical Council of India and National Medical Commission had 3 generic mandatory faculty development programs, they are not subject specific. It's broadly on medical education. So many of the people in the panel would agree with me, and we have so many who worked with me, Vinay, Kiran, Varun, Agyapal, and so many of them. We looked at the surveys. Very interestingly, 70% of the psychiatry faculty are keen to upskill themselves in undergraduate medical education, particularly in relation to psychiatry. Postgraduate psychiatry education, they want, how do we support training to the best for both UGs and PGs? They want some support in competency-based medical education, which came, and across numerous challenges, they are really keen to know. So this is why innovative strategies are required for capacity building in India. Now, what do we mean by innovation? We have to remember we are not inventing anything. We are just adding new value through solutions to meet the need. So it is in this context, we should understand why innovative strategies are required in Indian thing. Now, way back in 2011, we started to realize that we have to work very close with psychiatry teachers in capacity building. And we had numerous conferences in these years, CMEs, workshops, conferences at zones, nation. And we started exclusive national conference on psychiatry teaching. We did publications, papers, books, and many things. What we said was, innovation in psychiatry teachings are really necessary in numerous challenges we face in medical colleges. We should never forget that faculty should kindle interest in psychiatry. It should be learner-centered approach. It should be for every undergraduate or postgraduate. See, we are talking about a huge number, but we should remember every UG and a PG will make a difference. And the psychiatry teacher should never forget that one undergraduate student or one postgraduate student can make immense changes in our thoughts and actions, and they will deliver best for the community. We started to work with the faculty saying that it should be the learner who has to explore and understand various facets of psychiatry, and the learner should incorporate basic skills in psychiatry, and the learner should utilize those skills for gaining more knowledge to his benefits or his area of interest. And learning involves teachers and students as equal partners. This is a very tough job to say, but we should remember in acquisition and utilization of knowledge, it is mutually beneficial and rewarding when both the trainer and the trainee, they come together in this area. What we did was we started to look at, can we do many things in a crisp manner? So we started this Minds newsletter entirely for undergraduates and postgraduates. It has very 7 crisp sections. It is the India's first and oldest monthly. We brought 22 specialties from anatomy to neurosurgery and asked them to write about psychiatry. We brought innovative methods in teaching. We helped people to design crosswords in psychiatry to learn. And we brought psychiatry teachers across India to play a role of editorial things. Now, we pulled undergraduates and postgraduates also as co-editors, and this monthly has worked for 15 years. So you can imagine how we can generate concepts in terms of engaging postgraduates and undergraduates in the capacity building. The question is, does it really benefit? Does the user benefit from our this? So very interestingly, Professor Subodh was saying about whether it will have impact in certain areas, in rural areas, in communities. We could see that the undergraduates in a rural medical college like AIMS, which is down south, which is so secluded, we could see that undergraduate students started to participate in quiz. They went on to work in winning in UG at state, nation, and zone, even when psychiatry was not mandatory. Very interestingly, the model also worked in Malaysia. So you can see what happens in India or where happens in other countries. It makes sense in many countries so far. Now, does it really help doctors beyond curriculum when you have this approach? Yes, it does. We could see that some of these undergraduates, they started to come out with very bright ideas. For example, we talk about handling mental health of doctors. So these group of students, they only made a group. They started to say that we can handle sadness, we can stand this. So they came out with the publications. They came out with a very nice concept book, which is freely available. One thing I would like to tell you. So what happens with capacity building in the teachers also gets reflected in the undergraduate much. Now, with all these things, we thought that we should have one group, and Indian Teachers of Psychiatry, based on numerous surveys, we started to have a formal inauguration in 2016. Very interestingly, we had a one-day workshop on undergraduate psychiatry at the Rajiv Gandhi University in state of Karnataka, which is a major medical university. Now there are 60 medical colleges, 70 medical colleges in that university. The Indian Psychiatry Society and the National Institute of Mental Health and Neuroscience. And very interestingly, the Medical Council of India Regional Center at that time, they all came together at St. John's Medical Education Department, and we inaugurated it. And no pharma funding. It will be surprising to you that when faculty and the postgraduates and UGs are taking this spirit, it is possible. So what happened exactly? 30 medical colleges came, 5 universities. Whole day we had discussion about how to enhance this teaching and learning. And one of the things in capacity building of the psychiatry teachers, we discussed whether it is possible for the undergraduates to carry out research. We spoke about new models of engaging undergraduates in psychiatry research. We said how to do priming, how to work on consolidation of the group, and how to allow undergraduates to experience psychiatry research. And some of them went on to win the ICMR STS project. They published in the Indian Journal of Psychiatry. They went to national conferences. So you see the translation which happens with the innovative approaches. What was very interesting was when you have a capacity building, it should be led by faculty. There should be a peer group. And very interestingly, awards help us. So in 2018, the IToP initiative was awarded the International Neuropsychiatry Association Award in the area of public health, because what we do in psychiatry education has direct relation to public health. So this was the money we got, and we thought about what do you do, Professor Mohan, Professor Ashok, and myself. We thought about donating it to a trust, and we initiated the annual award for encouraging psychiatry teachers. And for the first time, we had national awards for Indian Teachers of Psychiatry to any teacher or a department of psychiatry for best initiative. And next year, we had separate, because there were many postgraduate and undergraduate institutions, we said we should give awards to the best practice both for undergraduates and postgraduates, because let them try some of the best strategies. And all the award winners in this year, what did they do and why they got the award is available in the Indian Teachers of Psychiatry website. It's free. Anybody can access it. So we thought allowing it to be in the this kind of online platform will only encourage people to look at it. Now, this was not an isolated event. We also, in addition, we started very innovative strategies like Raghuram Award in Karnataka. The psychiatry postgraduates at the Kempegoda Institute of Medical Science, they thought we should encourage psychiatrists, young teachers, because we were inspired by our psychiatry teachers. We need to do something for the teachers. So in 2011, the Indian Psychiatry Society Karnataka chapter, for the first time in India, started to give Best Teacher Award. And the first recipient was Dr. Jagdish Tirthali. Now he's head of the department of NIMHANS. So you can see the transformation which happens in these things. But we also gave awards to the best undergraduate in psychiatry in the name of Dr. Lakshmi Pandit, because we need to encourage the learner. There has to be some incentive for him. Since teachers and the trainees are at equal, we wanted to ensure. So these kind of initiative goes beyond our normal approaches in capacity building. Now, we understood when 2019, the National Medical Commission came out with competency-based medical education, there was a huge need to strengthen faculty in that. So right away in AIMS Rishikesh, we held 2 days workshop on competency-based medical education. And I think Shrija is here now, she's in UK. We all had a discussion. How do we strengthen psychiatry teachers in the competency medical education? And what kind of skills is required? What are these national strategies and all these things just before COVID time? Now, what happened out of it is that for the first time in India, AIMS Rishikesh, which is an autonomous institution, made psychiatry examination mandatory for medical students. So you can see how the transformation happens. What cannot be implemented to National Medical Commission in 800 medical colleges, the INIs can do it. And they showed that this is possible. We can engage the undergraduate in enhancing their training. So it inspired the psychiatry teachers. And in 2024, we came out with the entire manual on competency-based medical education. I think Dr. Anil is here, Dr. Christina is here, and so many of us, Dr. Vinay and Priya, many people, we sat together and gave what should be the competencies, how to take the teaching and training to the medical colleges, so that every teacher feel confident about what to teach, how to teach, what are the things. So, but this was an area which was not expanding. So we started to raise funds from the non-governmental organization. We tied up with the Minds United for Health Sciences and Humanity. Very interestingly, a school teacher had contributed 100,000 rupees to this trust. So you can imagine how passionate teachers can change. But this trust also received funds from patients. Teachers of psychiatry came together. Professor Mohan Isaac contributed. Professor C. Shamsundar contributed. And Infosys Foundation also came to support this thing. What we did with that, during the COVID time, we came up with a very novel capacity building strategy called as IToP steps. Scholarship for teachers towards enrichment of teaching skills. So it was launched in 2020 on the World Mental Health Day. It's a 20-session program spread over 3 to 4 months. Psychiatry teachers across India have to apply for this. They have to send a video of teaching. We have to interview them and we have to select. And from limited resources, we could give scholarship to 4 faculty, equal gender, equal preference to private and government institution every year. And we gave them 10,000 rupees at the end of their completion. Very interestingly, we had experts in psychiatry education from India and abroad who came to have a peer faculty group, and we enrolled a non-psychiatry expert in medical education as an observer. We started as online because during COVID, you could not do anything, but we also made it possible to offline, and it works on TOT model. These 4 people who are trained go on to train others in subsequent batches. From 2020 to 24, all 16 faculty who got this scholarship, they played a pivotal role in making many, many differences in various parts of India. And all their details are available in the website. And we presented this in the Royal College of Psychiatry conference, the International Congress in 2025. And that's where I had to meet in person Professor Subodh and so many of them at UK. What started as IToP steps now is called IToP Inspire. NIMHANS has started to give 16 fellowships in a year and 6 days of faculty day development program, which begins this year. So we have moved from a very low-key model to another model at the rest of the India. But we could see so many psychiatry teachers who are applying for this, but they had that ability to do. So then we thought about giving them educational research grant, a very small grant of 10,000 rupees in India. And over the year, they have to be trained under two or three peer faculty, usually in psychiatry education. It should be such work that any psychiatry teachers across India should be able to use it. So we have given some 30 grants in these years, and all details are available. What we made it, they have to mandatorily publish their data. So we got very novel ideas, such as how do we work with electives in undergraduate psychiatry? How do we come with entrustable professional activities? How do we train postgraduates or future teachers? All this was made available in a very special program called as Sunday Special 60 Minutes with Psychiatry Teachers. And it's in our YouTube channel. Anybody can use it. It's free. And psychiatry teachers across India, postgraduates, can benefit from such things. I want to come back to Professor Subodh's real concern. What is the outcome of our competencies? What is it meant for? At the end of the day, we want to connect with the community, serve the community, for which we need passionate and trained PG teachers. We need compassionate postgraduates. We need resources. We need patience and so many things, appropriate curriculum, training methods, evaluation. This is a very complex thing. And how do we do for postgraduates in India? But we did not have a model in India. So what we thought in 2019, we came out with capacity building resource material. It is perspective on psychiatry training. Dr. Suhas at St. John's played a key role. And we designed the entire module. And we went from places to talk about this module. Competency-based medical education workshop for postgraduates and psychiatry teachers. We did it in Agra, Lucknow, Calcutta, Srinagar, Bangalore, Patna, and so many places. We collaborated with many organizations, Indian Psychiatry Society, Indian Association of Social Psychiatry, and we started to give travel grants for young teachers to go and attend these kind of workshops wherever it is happening, so that we have a model which can be used in our own context. Now, what we understood, unless there is some kind of capacity building of psychiatry teachers on key areas, we will not be able to do justice. So in the couple of years, there were a lot of questions about what is the format of psychiatry history taking, how do you do mental status examination, what should be taught for undergraduates, what is required for postgraduates, what do you mean by diagnostic formulation, what do you do in psychotherapy training, what kind of neuromodulation training is possible, can the curriculum be same for INIs, can there be mentorship program, and what should be the revision of psychiatry curriculum for India. And we started to work on surveys, discussions, and in this couple of years, we came with consensus on many, many areas with lot of discussions and deliberation. And these documents are now available. Now we have to carefully work with psychiatry teachers to see that they use these resources, upgrade it, modify it, and see how it can be incorporated. So the latest we tried was in the curriculum revision for competency-based medical education. We thought of linking competencies with entrustable professional activity and allow some flexibility for regions and institutions where they are doing real good job. So these are some of the things, and we involved postgraduates in this, we involved undergraduates in this, we involved some patients and their family members also, so that there is a meaning to what we do. And these things helped us a lot. And our major drawback in India was there was gross deficit of psychotherapy skills in India. Faculty did not have training. Postgraduate did not have training. Dr. Ajay is there in the platform. His study, which came in Indian Journal of Psychiatry, huge deficit. 70% of the institutions and faculty say that there is no or minimal training in psychotherapy. So last year, we started scholarship for psychotherapy supervised sessions. We wanted to ensure faculty get trained with a supervisor. Luckily, we had Professor Matthew Verghese and Professor Pratap Sharan who pitched in, and they said they will bring the capacity building. So we started online programs. Professor Pratap Sharan is good. Professor Matthew Verghese already has 2 teams. We got offline sessions by Professor Raghuram, who pitched in, and in Bangalore, in the last 3 or 6 months, he's doing. It's a very, very different strategy. We asked people to apply. We did interview. It is a 3 to 6 months of supervision, but we put an external evaluator to see pre and post, is there real difference in what they are learning. And for the first time, we also had a national conference on psychotherapy at AIIMS Bhopal, where we held workshops on psychotherapy training. We had organized some workshops in 2024 IToPs also. We gave awards for people who are doing psychotherapy training. And we came up with a discussion with the editors across India. What kind of work is required to be portrayed? What kind of research is required? And that is also available in the YouTube. Luckily, some of the funders, they said they will give away a small award for young faculty in psychiatry who are teaching psychotherapy. It is called IToP Samvad Award. Just we rolled out a couple of months so that we encourage faculty to do such things. And I want to remember Professor C. Shamsundar, who revived psychotherapy training in NIMHANS around 3 decades back. He said, psychotherapy training, it should be a movement or ideology that should be pursued all time, a forum of interest. How do we do it and how we can do it is something we have to put it to the group to do it, but we have started something. Now, we do so many things. Where do you record it? So we started to put all the data in some of the best journals. Very interestingly, the Indian Journal of Psychological Medicine dedicated a thematic issue on academic psychiatry 2024. The entire issue has pan-India work on what can be done at undergraduate, postgraduate quality training. Now, are available in websites. We have around network of 12 states in India. Just 2 days back, we released the teaching and training in South Asia. So this is an amazing work. Some of the best people, I think Yasir is there from Bangladesh, Sujitkar, and so many, Professor Mohan, they all came together. We had some of the best people to work on it, and this book is now available. But I remember what Professor Rajshri Ray was saying and Professor Subodh, that how do we work with newer things which are emerging? So we wanted to know the need of AI in psychiatry education. We thought about it in 2024 IToP conference and 2025. So we pulled up the professor from Indian Institute of Science, Professor Suresh Sundaram. He started a focus group approach with selected faculty from psychiatry across India. We started to discuss. We have held 3 or 4 meetings. How do we work with psychiatry teachers and education? So this is a new area, and we are seeing how we can collaborate. But we should remember there are newer and newer areas coming up for psychiatry teachers. We are talking about One Health, climate change, and we wanted to see some of these things. We started a campus nature club. We believe that we are rooted in nature, growing together, and the flora and fauna are interesting to intricate life on Earth, more so for humans. So we want to see whether undergraduates and postgraduates also blend with the environment, with the changes which are happening. Do they understand these roles in One Health? So these are some of the new strategies we are trying. And I remember what Professor Subodh was saying. What about the mental health and well-being of the campus doctors? Are there any way we can do capacity building for them? How do we allow postgraduates, undergraduates to learn beyond the books? So we started book clubs. Now we have around 8 years of experience in it. It works really well. We have 3 institutions who are working on this area. How does it work for mental health in the campus? What do you mean by well-being? Does it really work? And these are some of the things. But unless we partner with technology, we can't do much. So when the National Medical Commission said that you have to train 250 doctors, 150 to 250 doctors in every medical college, where there are only 2 psychiatry teachers, how is it possible to train such a big number unless we have some kind of technology partners? So we thought of assisting psychiatry teachers in some of the apps which we designed. It's a very simple app. It's only 1.26 MB. We ensured that privacy is maintained. We thought of not keeping any personal data. It does not work with internet once you download. We started to see whether it works in medical colleges. We tried in Bangalore Medical College and JSS Medical College. It has a lot of promising evidence to assist psychiatry teachers in training. It helps in consolidating time, but also it helps undergraduates and postgraduates to use the technology. Obviously, there are many questions, but we are doing much on this. I come to last part of my session on what do you mean by thinking out of box? What we believe is if there is any way to do it better, like Thomas Edison said, we should try it. Innovations in capacity building, like any idea, by definition will not be accepted. It's very difficult to accept many things for psychiatry teachers, PGs, undergraduates. It takes repeated attempts, endless demonstration, monotonous rehearsal before innovation can be accepted, internalized by organization. And it requires courageous patience. So innovative capacity building strategies in psychiatry education is in that context. And I'm really thankful to all for making this happen. And we are keenly going to listen to everyone. Thank you so much. I would stop my slide presentation and move back to Professor Rajsire. Over to you.
Thank you.
Yeah.
This was, and from the comments that's been coming, you realize how powerful your presentation was, Professor Kishor. Your journey, I would say your team's journey of 15 years, really, starting with a vision. And this vision seemed very focused, very passionate, with exact goals. You had some clarity in your mind right from the beginning. When I say you, I mean your team, your mentors, your students, everyone who worked together. And the clarity, what struck me in your journey, as you said, you kept on experiencing it, evidencing it, doing the research work, and then really bring the research back into practice. And then moving on to see, and you're testing it continuously, you tested it, and you rewarded your people. You rewarded them through acknowledgements, through awards, through opportunities, through gratitude, through newsletters, wherever, you just had a sense of what was going right, what was not going right. So the collaboration was really at its best to bring forward new pathways. And it's so wonderful to see your book being published. Many congratulations. I'm sure we are the first public forum where you've announced it. So we feel very privileged that we've been part of this journey with you. And of course, as Professor Dave started sort of very interestingly saying that, technology, and it's brilliant that you've used Indian Institute of IISR, the best top university in the country, to sort of get into things together, and love the collaborations that you've had. You need to expand the collaborations to East India as well, to the eastern part of the world where I am in India, because everything seems to be down in sort of, Rishikesh and all the brilliant places, but we need to make it accessible to us, like in private medical colleges, where we really need people like you to come. But
Yeah.
I will not take, but so thank you, incredible, both of you, Subodh and Professor Kishor, it's been great. Now we come to a legend. And Professor Mohan Isaac, I think I've forgotten the words, which was a living and breathing legend, as I would say, sir. Thank you for joining us. And I really don't think he needs much introduction, but let's take over the floor and address our audience. Good evening, Professor Isaac.
Thank you very much, the moderator of this evening's program, Dr. Rajshri, who is the chair of the South Asia Division of the Royal College of Psychiatrists, Dr. Subodh, who is the Dean of the Royal College of Psychiatrists, and Dr. Kishor, Professor and Chair of the Department of Psychiatry at JSS Medical College. Today, I am indeed excited and delighted that this kind of a program is taking. I'll tell you why I'm so excited. This is something, which does not usually occur. The Royal College of Psychiatrists, of course, I mean, the Dean is here. There are other members who might be participating. It is an old training institute which sort of guides the training of psychiatrists, not just in the old British Commonwealth, but all over the world. In Australia, most of the training program, although the Australian college would not agree, is largely a ditto of the Royal College of Psychiatrists. The training that I underwent in psychiatry more than 50 years ago in Bangalore was a replica of the Maudsley model of training in psychiatry. So Royal College of Psychiatrists is in a way, it has a major role in the field of psychiatry, not just in Britain, not just in the old colonies of Britain, but all over the world. Now, the Royal College of Psychiatrists, through its South Asia division, is collaborating with an organization in India, which is called the Indian Teachers of Psychiatry. You heard from its current president, Kishor, about its various activities. Now, this kind of a collaboration on capacity building in the field of psychiatric training, I think, is what excites me. I'll tell you why this excites me. Because I believe, now let me also say a couple of things about me. I'm excited about the year 2026 because it was in 1976, 50 years ago, that I joined after completing my initial training in psychiatry. That was at DPM, followed by an MD at NIMHANS, which was called the All India Institute of Mental Health. I told you that our training, we learned the Mayer Gross textbook of psychiatry, edited by Slater and Roth, Elliot Slater and Martin Roth, and it was a replica of the training that went on in Maudsley those days. Why I say it was a replica? Because many of our teachers were trained in Maudsley. So I finished my training, and it was in 1976 that I joined the staff at the lowest level. Then, of course, I became a lecturer, assistant professor, and then ultimately retired as a professor and chair of the department. So 50 years is a golden jubilee. It's important to remember the year that you joined as a staff. But that is not what excites me about this program. What excites me is that I reflect on how psychiatry has changed in the past 50 years. Or has it changed at all? Is there any change in the way I manage people with severe mental disorders today? Somebody whom we diagnose as schizophrenia? Of course, there is a change. Those days we used to give chlorpromazine or haloperidol or the first generation long-acting antipsychotic injection, anetensol, flufenazine decoinate. We made people, stoop like Parkinsonian patients. They would stoop around. Anybody could make out who was on his antipsychotic medication. Of course, we don't see that now. But what do my colleagues, non-mental health, medical, as well as other non-professional colleagues talk about psychiatric patients? They are obese. They are triple their size. Before starting their treatment, they were only 1/3 their weight. Now, the point I'm trying to say is psychiatry has changed. I mean, many young people might think, what is this old professor talking about? Not very pleasant things. But that is a reality. We still have very complex cases. We still have treatment-resistant cases, etc. Managing people with severe mental disorders is still a challenge. We may have moved from the first generation to second generation. So while psychiatry training and practice has changed immensely over the past 100 years, I'm more familiar with the 50 years because I've been a teacher in some of the best institutions in India and elsewhere. I've also worked for about 3 years in the World Health Organization based in Geneva. I must say that psychiatry practice has been changing. We were, alienists or asylum doctors, then we became psychopathologists, then we became psychoanalysts, then we became psychopharmacologists. Many of us are still, we take pride in saying that we are psychopharmacologists. But the reality in most developed countries, not so much in India, but in Australia and UK, etc., well, psychiatrists are leaders of mental health teams. And also the fact is that psychiatrists constitute only about 5 to 7% of the mental health workforce. There are social workers, there are counselors, there are occupational therapists, there are psychiatrically trained nurses. We must remember that while we are probably the most effective and most important members of the team, we constitute only about 7, maybe less than 10% of the total mental health workforce in any country in the world. But there is one more thing which I want to highlight at this point in time, and that is another reason why I'm concerned. I'm excited about this kind of a program. We are probably the only amongst all physicians, I'm talking about all doctors, internists and surgeons and dermatologists, amongst all the physicians, we are the only physicians with a unique skill. I'm talking about the psychotherapeutic skill. That is something which all over the world, in UK, in Australia, I can say where I'm working now in India, there has been declining interest, declining emphasis, declining importance in the training, etc. A unique skill which we, amongst all physicians, only we as psychiatrists possess, we are neglecting. So why I mentioned all this is, based on my reflection of past 50 years, I think psychiatric practice will change immensely. It's already begun changing in the next 10, 20 years. And consequently, psychiatric training has also to change. Of course, when we all thought of this kind of a workshop on capacity building, as Kishor said, we don't have enough teachers in India. There are a large number of training centers. UK has a long tradition and very rich experience. We could exchange notes and we could learn from the training experience and traditions of UK and bring it to India and equip our teachers. That is, of course, important. But for me, more importantly, both in UK, in United States, in Australia, everywhere in the world, psychiatry trainers, people responsible for psychiatric training, have to give a serious thought to how psychiatry is changing, how the future psychiatrists have to be different. I'll just tell you a few things. I mean, we deal with, when I trained, of course, I wrote notes. Today, all my residents, it's all electronic data. I'm talking about digital data, mobile technology, mobile and computer-based treatment programs. I do not want to venture into this new topic, but which is already in front of us. I'm talking about artificial intelligence driven algorithms and how that is going to change our things, etc. And more of measurement-based care, more of integrated care. I said we are only leaders of a mental health care team. And with all this, something which I mentioned earlier, have severe mental illness changed? Have we found out the final solution for bipolar affective disorder and BPAD? So complex cases continue, complex problem treatment resistance continue. So the future psychiatrist has to deal with all this. He has to be a team leader. He has to be all these that I mentioned. So I think, I hope that this is only the beginning of a kind of a dialogue between an institution such as the Royal College of Psychiatry with long years of very rich tradition of training psychiatrists for the whole world, at least a major part of the world. And as Kishor said, one of the countries which is training large number of doctors. I mean, he mentioned, I think, 1 billion. But it's also true some of the best doctors in the world, in large parts of the world, are doctors from India. This is not my own statement. This is widely accepted. The best doctors in UK, best doctors in United States, not just psychiatrists, amongst all doctors are Indian trained doctors. So I am excited that this kind of a dialogue has begun, and I hope this will continue to facilitate capacity building for teaching and training. And I think this kind of a dialogue, which also will look into how the psychiatry training itself should change, how we can bring in some of these AI, computer-based, the new psychiatrist who is a leader. He has to be a charismatic leader because, we have a big task in front of us, and maybe we are not at the moment adequately trained. So this is my excitement. I'm so happy that this we have listened to two excellent talks. Subodh from his long years of experience. In fact, I have been associated with Kishor and many other youngsters about Indian teachers of psychiatry. And one of the first things I saw is Kishor and Rajshri and many others. They had an association of psychiatry teachers. I forget. I remember looking into your website, your logo, and all that. And I told Kishore, see, look, you are not the only guys. There are also people who are, equally concerned about improving the quality of training and equipping the psychiatry teachers who are not themselves trained as teachers, equipping them with skills of training. And that is how this came about, and this collaboration has sort of come about. I mean, I now know from all the emails that I had the privilege to go through, this is not just a temporary arrangement. There is a formal arrangement with the Royal College of Psychiatrists and the Indian Teachers of Psychiatry. And as I conclude, I must also take credit for one more thing, that there are not many people who are in the RCPsych who are members, perhaps not very active, but fairly active members of two divisions simultaneously. I work about 50% of the time in India and the other 50% of the time in Australia. So I am also a signatory to the Western Pacific Division of the Royal College of Psychiatrists. Subodh, you may like to know that, being the dean, etc. So I'm delighted that the South Asia Division has taken a lead, and many of the things that we are discussing are equally relevant for all the divisions. In fact, I'm saying it is not just for the RCPsych and the Indian Psychiatric Society, but it is relevant for all psychiatric teachers all over the world. Thank you very much, and back to you, Raj.
Thank you so very much, and I'm sure you'll be delighted, Professor Isaac, to know that one of the webinars we did from the South Asian Division last year was actually a collaboration with the Western Pacific, and Subodh was also there. Yes. So we did one on. So Subodh encourages us to do a lot of collaborative work, and it's glad that you belong to both the divisions. We should be one world. So I think we have a few minutes. I mean, we should extend the time by another 5 minutes. I hope that's all right. But we think there has been some interesting questions in the Q&A section, and there are certain comments as well. So shall we take the Q&As first quickly, Subodh? This was after your talk about the burnout in doctors and the doctors in distress that you, the organization that you have. So it's from Dr. Sachi Khanna, and she wants to know, how do we tackle the fact that doctors from other branches might themselves be hesitant to come forward and seek help when experiencing burnout? Very relevant. Subodh, would you want to?
Yeah, great question, Sachi. I think so. You're right. I think the first thing is to recognize, and I think this is something that I remember saying on BBC Breakfast, that it's strange that only in medicine that we find that, if even in India now you see people on a building site are required to wear protective gear, In medicine, nursing, a profession, you're guaranteed that you will come across morbidity, mortality, distress, and literally there's nothing to prepare you for it. And we expect you to learn it on the way, on the job somehow. So I think putting it in the curriculum, I think is important. Recognizing distress is important. Having systems that will support you when you are distressed, I think is important. But there's also, I think, a culture change that is needed. I think a lot of this is about being human. I think even within medicine, and Sachi, maybe this is what you're alluding to. I think I had this issue, I think, a couple of years ago. I was on crutches, I was walking through the hospital corridors, and about 50 people stopped me asking, what's happening? What happened to you? And I think, Mohan, I don't know whether you remember Professor Bhomik, when he passed away, I think my mentor sent a little note to my team. And out of a team of 70, about 2 people to say that, I'm a bit upset, that this has happened kind of thing. But 2 people responded. So I think it's something that we also can be a part of, where we don't reach out to people when they are psychologically distressed, but when they're physically distressed, we're happy to kind of have a conversation with people. But it's not hard, I think we teach our medical students, we learn how to ask difficult questions, like, asking an 80-year-old woman her substance misuse history. You still take a thorough history, you don't skip questions just because somebody's 80, and that's not good medicine. I think in the same way, I think we learn how to ask about suicidal ideation. So if we don't know how to approach someone in psychological distress, we should learn how to do it, And I think that's something that I think every organization, how people, wherever you are, can check that and find out as to what's happening. Do people feel comfortable asking? And if they don't, I think that's something that can be learned. And I know, Dr. Kishor, you have plans to come introduce some of that in your training program.
Yes, and of course, this whole question about, our ability to acknowledge physical illnesses much more readily than psychological illnesses is just not just when we are doctors. It starts from even for children, school students across. It's a general issue. It's a global problem, and that there are a lot of discussions we've had on this, whether it's a stigma associated because of this, or it's just a culture change. But whatever the reason is, we've talked about reasons for a long time. It's real time to do the action bit. And action starts from us. Action starts with us. And interestingly, as you start thinking, I'm not sure, someone said, like, even one student, if we change the undergraduate, one student, if we change in the postgraduate, imagine Professor Isaac one day was just that one student in his whole class 50 years ago. And today he's that candle that's lighting other candles. So that one student has changed. Even one Professor Subodh Dave in his Mumbai University one day was a young Subodh Dave who probably left his IIT Mumbai seat and decided to pursue medicine. And today he's leading the world from the Royal College and said same thing can be done, sort of talked Dr. Kishore. But 50 years ago, we never thought of that. And even someone today might be another Professor Kishore or Professor Dave or Professor Isaac 50 years later. So change has to start. And on the same thing, Subodh, if you don't mind, I'm going to take a very set of a related question here. And apologies if I do not pronounce the name correctly. Dr. Chioma Nengwa sort of says, hello, at what point can you say you feel burnt out? Subodh, it's a very linked question, if we can take this now.
Yeah, so it's a good question. It's a technical question, Chioma. I think, Chioma, what it means is stress is we probably all experience stress, where we begin to experience difficulty in managing our current situation and associated with both physical and psychological symptoms of anxiety. Burnout is experiencing those symptoms in the context of your workplace. So it's an occupational distress. If you go away on a holiday, you're feeling fine. If you're back at work, you start experiencing those symptoms all over again. I think some of the key symptoms are things like cynicism, you're losing the joy at work, not feeling the excitement, the intellectual and the emotional fulfillment that comes with your work. I think especially in medicine, I think we work where we can make a difference in somebody else's life, and then that gives us that sense of fulfillment and joy. If you don't get that, then that's usually a good sign to kind of watch out for. But common symptoms of anxiety, etc., but only specific to the workplace, again, are similar signs of burnout.
Thank you for that. Dr. Arif has been very engaging all through this webinar, and so thank you for that, Dr. Arif. He's from Kashmir, and his question to us, and I think it involves all of us in the panel, in a big country like India, seats in postgraduate psychiatry are limited. Can the Royal College and the Indian Psychiatric Society start an orientation course for the MBBS graduates? And in 2013, he refers that the college had conducted the mental health gap training. I think that was happening in Kashmir. There's a lot of work that has happened in Kashmir before. So can such orientation be started again? Because so many patients of dementia are there and other sort of numbers. So there is, as Professor Isaac said, work has started. Subodh, maybe as the dean, we would want to maybe, give us a brief idea about the IToP work and the Royal College work and the other
Yeah.
collaborations that started?
Well,
in
briefly,
many
I think
grounds?
it's mostly in your domain. So, we have the international divisions of the college. The college is an international college. We have 6 international divisions. And actually, you are leading the South Asian division, and this is your domain. I think if you feel that Kashmir has a specific need, that's something I'm sure actually you can look at as in your capacity as chair. And
Yes.
certainly in my role as the college officer, the dean, I'm always willing to work with collaborators. And that's how this particular webinar has come about, Dr. Kishor. And I hope that we'll build on these collaborations to build capacity. I think just one thing to say is that the college is very committed to building capacity globally. I think, we sometimes can think very narrowly, but the reality is that globally there's a shortage of psychiatrists and people do move. There's no way that we can hold on to psychiatrists either in the UK or in India. People move across domains. So I think if we all improve together, we all will get better. And I think that's the important thing. We're all in this together. The problem of workforce shortage is our global problem, not the problem of one single country.
Absolutely. Dr. Arif, and also for Subodh, we've recently had some dialogues with colleagues from Kashmir, specifically with Professor Muhammad, who's the presidential lead. So, Dr. Arif, do drop us a line. Let us know if we can tie up those very initial conversations that's happened with some colleagues of Kashmir who's also keen on getting some Royal College sort of together collaborative work. So we're very happy to see if we can tie the things together and make it more meaningful. So that's the question. I hope that answers it. So do drop me an email message and we will get on to work on that with you. And Dr. Bhubaneshwari Seturaman has asked how to operationalize a recurrent task of training the assessors of MBBS students. Professor Kishor, I think this is something that you might, from your experience of many years of working, might want to take this.
A serious challenge is assessment at any level. Remember,
Sorry, it's not very clear, unfortunately. Or is it my end?
No, I think it's breaking up for all of us. I think your signal is probably weakened, Dr. Kishore. It's breaking up. I think while Dr. Kishore's adjusting his sound.
So I think
come
Dr.
back?
Ajay, you're coming back?
Is it audible?
Yes,
Yeah.
much better.
Now
Thank
it is.
you. Great.
Yeah. So I believe there are serious challenges about how do we do assessment for undergraduates because of the numerous factors and the huge number and the diversity we have. But I think St. John's Medical College has come out with very innovative strategies which are now available in the Indian Journal of Psychiatry and Indian Journal of Psychological Medicine about how do we do these kind of assessments. And since the NMC, National Medical Commission, does not want us to look at the clinical skills except the certifiable skill, which will come up only in 2017. At this point of time, the psychiatry teachers do not play any kind of role in the assessment because the theory and other things are evaluated by the Department of Medicine wherever they are placed. And we should really look in 2027, how do we take up this new challenge? But there is also a very nice document which has come from All India Institute of Medical Science, Rishikesh, which has devised a strategy of looking at psychiatry faculty's ability to do assessment for undergraduates. I think these are the two important models for us. I believe, Bhuvaneshwari, you got the point.
Great. So I think that's the end of the question answer session. Quite a few lists. And on that note, thank you, Dick, as well, and Professor Kishor. Subodh has to leave, but Professor, bring this webinar to a close.
Sorry, I lost the communication.
Professor Isaac? No. Yes.
Yeah.
Professor Isaac? Yes, sir. Over to you.
Somebody asked a question about burnout, etc. I just want to recommend a podcast of Subodh being interviewed by Dr. Harkishan in India. The whole 1.5 hour podcast, Subodh is being interviewed about this topic on burnout amongst doctors. In fact, the title of the YouTube podcast is Burnout, the Hidden Epidemic, or something like that. I could send to the Royal College the link to that podcast, and I would suggest that everybody watches it because he covers lots of aspects about burnout, what needs to be done, how can it be dealt with, etc., etc. That's all.
That's
Back
a
to you.
very wonderful resource, actually. Thank you for reminding us of that, Professor Isaac. Harkishan, Dr. Mamdani is also a member of the Royal College from the South Asian Division, a very active member indeed, and he's actually been doing a series of podcasts. So it's if you just Google it, that's a great. So thank you for reminding that as well. And he's been doing that pretty frequently these days. So a lot of work behind the scenes. So thank you. All right, so kindly delegates, thank you for staying with us for additional time. We'll be very grateful if you're able to complete the feedback form that helps us to improve things, and also it's a requirement from our college to ensure we are able to deliver these webinars. Thank you to Patricia and Sam, who's worked tirelessly behind the scenes, not just today, but over the last few months to bring us all together. And on that note, wishing you a very good night, good afternoon, and take care till we meet again. Thank you all.
Thank you.
Bye.
Thank you all.
Bye-bye.
Thank you.
Bye.
Bye.
Bye.